what I'll do is I'll go through my experience. I'll go through very briefly the 30,000-foot view of the MIS system. I'll go through a few of my cases. I'll put up a video just to kind of show how I do it, and we'll kind of go from there. Here we go. So my experience, it's actually 2016. I went to the EFAS meeting to present some data, and Wright Medical had a lab that they were doing for a minimally invasive bunion. And for any of you that know Dr. Joel Vernois, pretty charismatic, definitely better head of hair than I have. And I really was enamored with the technology and just how convicted he was and convinced that he was that it really improved his practice, improved his patients' outcomes. And even though I had learned it 2 years prior, it took me a little bit of time and I was a little reticent to go ahead and do the first one. But in 2018, I had a nice young lady who came in. She had been to 4 of the surgeons looking for somebody to do a minimally invasive bunion. And she came to me and she was like, look, I've been to 4 other people. Everybody says they do minimally invasive, but nobody will actually do it for me. So I said, well, why not? I know how to do it. The guys over in Europe are getting good results. Let me call in a favor and see if I can get the RV into town. And thankfully the RV was there. Funny story about the RV is I wanted to do a left and a right. So they thawed 2 different specimens for me. They actually were for the same patient, and it was actually an achondroplastic dwarf, so the feet were too small for me to actually practice on. So we had some choice words, and then the next day they brought it back, and I actually had a real foot, and we were able to practice a little bit before I did the first case. So that first case was really very eye-opening to me, and before that, I've done Lapidus. Scarf was my real workhorse. But I did chevrons, I did Ludloffs, I did a lot of different osteotomies, and I was really, really kind of by the book. I looked at the intermetatarsal angle, the hallux valgus angle, the sesamoid station, if there was any rotation, and I followed the algorithm. And this first case, the young lady came back to me at 2 weeks, and she had taken her dressings off herself, had put herself back into her Tory Burch sandals, and was walking in like nothing happened. And I couldn't believe it. I was like, this is it. This is what I have to do. So currently now, this is my workhorse procedure. I always tell my residents and fellows that you need to find a procedure that works in your hands, and that should be your go-to unless there's an indication that you need to do something else. And right now I'm correcting about 90% of hallux valgus through a minimally invasive technique. If you include bilaterals, I've done 172 of these so far. I've only had 7 complications. 4 of them were hardware removals. One was actually a chemical burn from the skin prep. It wasn't even at the bunion site, but if you're being a purist about looking at your data, this is a complication. One person had a delayed wound complication. I put my patients back into shoes in 2 weeks, and I think the young lady just kind of got after it. She was on her treadmill and on her Stairmaster, and she came in and she had irritated the where the osteotomy is done, and I wound up having to put her on oral antibiotics, but didn't need to take her back. And then I had one patient who had iatrogenic shortening with metatarsalgia. My personal opinion, you should adopt this. This is a procedure that is highly reliable. Once you get the hang of it, it's reproducible, and for lack of sounding like an extremist, I don't really think there are many bunions that you can't correct through a minimally invasive procedure. And my practice has had a real paradigm shift. I did my fair share of forefoot, but I would tell you on any given week, I see about 15 to 20 people who we sign up for bunions. And there's a good share of people who are flying from out of state who come in, I do their bunion, they fly home 2 days later, and we Zoom at 2 weeks and we Zoom at 6 weeks. And if there's no issues, and knock on wood, there hasn't been any issues, I don't hear from them again unless they text me or email me. And we've done people, last week we did a young lady from Minnesota. We've had people from New York, from the Northeast, from the Pacific Northwest, from South Carolina, you name it, they're coming in and we have it streamlined now. They come in on a Wednesday, we do their surgery on a Friday, and on Sunday they're flying back. So this is something that if you adopt it and you're comfortable doing it, I think you'll find that this becomes one of those procedures, one of those techniques, and one of those technologies that is practice changing. And there's a few of those that have come up through, my career. One is the total ankle prophecy, and this is the next one. And I'm sure for some of the other surgeons out there, they have ones in their mind, but this has changed my practice, and it's really easy to talk about something that you thoroughly believe in. So I'm always open. You all can always reach out to me, talk to me. I'll send you videos. I'll tell you what I know and what I can help you with, because experience really is the best teacher. So the ideal feature for your metatarsal osteotomy, you got to get adequate displacement. It's got to be reproducible. You got to have stable fixation. It needs to be anatomically, biologically safe. So you don't want to damage the blood supply. You don't want to have necrosis of the bone leading to non-union, and you don't want to injure the surrounding structures like the soft tissue. You also don't want to disrupt the capsule if at all possible, because this avoids stiffness. I think that this, for me, really hits all of those. It's a high torque, low RPM burr, so you're not getting thermal necrosis. It also has a little irrigator on it, so you're not getting soft tissue necrosis. You're staying out of the joint capsule, so you don't see the stiffness that you get when you do your medial capsule repair and plication. And you're not injuring the surrounding structures. And one of the ways that I avoid that is on my incision that I'm doing the osteotomy through, I always stick a freer in to free up the periosteum, just to avoid dinging that dorsal medial cutaneous nerve. I really have had good results with the patients not having hypertrophic scars. They don't get the swelling that you see with open bunions. I remember my scarfs, at 3 months, they'd be coming back in and really complaining about getting back into shoe wear comfortably. They have to wear a size bigger just because they still have soft tissue swelling. And that is not the case. I really have to slow my patients down, because the patients come back and they're at 6 weeks and they're saying, I'm running 2 or 3 miles, and I'm like, oh my goodness, you shouldn't be doing that, but they do. So the evolution of the techniques, we'll really briefly talk about this just in simple terms. The early results were really crummy. I think it saw a resurgence in Europe with the minimally invasive group out there, and they refined some of the techniques, they refined some of the instrumentation, and they refined some of the hardware, and those results are sort of where we've sort of piggybacked on to bring it and introduce it here in the United States. And my results have sort of echoed that they saw in Europe. And again, anything I could do to help you all sort of figure this out and get comfortable, because this is not, your mentor's AO technique. You look at an X-ray and it's not going to be as pretty as, a scarf or a Ludloff or a lapidus or a proximal crescentic, but it works. So we know the literature, there's less pain. Most of my patients come back and they tell me they didn't take any pain medicine, or they took pain medicine for the first 2 days. My patients in shoes by 3 to 4 weeks, 6 weeks is probably the far end of when my patients get back into shoes. And what I tell all my patients is the benefit of doing this is not a year down the road. It's not 2 years down the road. It's the immediate benefit that you get. You don't have the discomfort. You don't have the swelling, and you really are able to get up and take care of yourself. The scarring is minimal. There are patients, and we just hired an MA from one of the surrounding areas who worked for a foot and ankle surgeon, and I brought her into one of my 1-year bunions, and I said, "Where are the scars?" And she's like, "You did a bunion on that?" And I said, "Absolutely." And she couldn't believe it. And I showed her the X-rays, and she's like, "Holy cow, that's incredible." And the patients are happy. The patients are probably my primary source of referral. I mean, I'm doing like families of bunions. Last week I did the last member of a family. I did all 6 of the women in the family's bunions, and it's kind of cool to see that the patients are sending other people your way, because they're so happy and they all hear the horror stories. And we've all talked and counseled the patients that it's not as bad as all the horror stories that you hear out there. And this is just something that if you do it, the word of mouth is going to really take off, and you are going to see a tremendous uptick in the amount of bunions that you're doing in your practice. So with the PROstep, you do an obtuse angle chevron. I think it's important just to mention here, you got to trust your anatomy. We've all done open chevrons. You should do it the same way, minimally invasive, and it's all about the motion in your wrist. You're not pushing the burr. You're actually pronating, supinating your wrist to get it across. What I would tell you here, be really, really, really liberal with your use of fluoro initially until you get comfortable. And once you're good, I take 2 or 3 shots and I'm done. You do it right at the metadiaphyseal junction. So when I'm looking, I mark all my spots on fluoro. I mark right at that spot, and I know that's where I'm going to make my osteotomy. It's extracapsular, so again, you're not doing any capsular work. So theoretically, and in my practice, you're not getting that stiffness from that medial plication. The only real soft tissue dissection I do, again, is off of that osteotomy incision to make sure that I don't wrap up the dorsal medial cutaneous nerve. It gives you really, really rigid internal fixation, and I challenge any of you, do the procedure and then go live on fluoro and crank the toe back and forth, and you will see how stable this thing is. And I usually combine it with a soft tissue release, and I would say about 50% of my patients are getting an Aiken. They're walking the day of in a rigid post-operative shoe, and they come back at 2 weeks, and I tell them sometime in the next 2 weeks you can start weaning into a regular shoe as you're comfortable. Allow pain to be your guide, and then the burrs that come with it, you have your array of different burrs. So my indications, just about, and I know what the technique says, but I would tell you that just about any bunion that I see, as long as there's not hardware or arthritis, I can do, because I'm comfortable displacing the osteotomy greater than 100%. And I'll show you a picture to prove that it heals. And I don't have an explanation for it other than to say, because you're not disrupting all of the periosteum, you have that periosteal sleeve, and just like with mescalet, the bone forms through the periosteum. The bone does. The bone grows across your osteotomy, and you see it, and it's really kind of cool. So obviously, infection, you're not putting hardware in. Inadequate patients, I mean, it is what it is. Any irreparable tendon, so if you have cock-up deformities or any type of sesamoid metatarsal complex issues, clearly it's not an indication. You know, bunions are not elective procedures, or in the sense that they're not cosmetic. So patients who come in with no pain, I shake their hand and I say, when you have pain, come on back. So those are the ones that get conservative treatment in my practice. Open physes, you're not going to put hardware across a physis. And I haven't seen this, but patients with high level of activity, I think you just need to caution them that they can't get into that level of activity for a little time. And even if their pain is not there, you know, biology is biology. Biology doesn't change. Osteopenic bone, I will avoid bilateral surgery in some of those patients. On those cases, I'm doing 100%, I'm doing 2 screws. Some of the patients I'm getting away with 1 screw. Arthritis is the first MTP. Those are getting a fusion still in my hands. First TMT, arthritis with instability, I'm still doing a Lapidus. Uncontrolled diabetes with sensory loss, those are not getting this procedure. Inflammatory arthritis, if they have cystic changes in the bone where you're not going to have good purchase, those are people who I'm avoiding this in. And then again, sesamoid pathology, any bunion you do, if somebody has wicked metatarsal sesamoid arthritis, they're still going to have pain through plantar flexion, dorsiflexion, because they're getting pain in the plantar aspect of the first MTP joint. So for this, the feet hang over the end of the table if you're doing bilateral in my hands. If you're doing a unilateral, I think the best way to do this is to use a piece of bone foam or elevate the foot above the other foot. And the reason is you can quickly switch from AP to lateral without having the other foot get in your way, without hitting the other foot with your cam of your mini C-arm. And then I have the mini C-arm come from the foot of the bed. And the mini C-arm that we use cams forward so you can actually get a really nice AP and swing it to a lateral very easily. I put the burr on the contralateral side, the scrub nurse is on the ipsilateral side, and you have the saline cooling irrigation system, which I think is helpful. So this is the setup that they have, and you can see the fluoro is actually from the side of the patient. I don't think that that's necessary, and I like to work from the foot of the bed, and the reason is that you can work from either side of the fluoro. If you have it on one side, it's hard to get your hands in between, so I like to be free on both sides so I can come in with one hand to hold and the other hand to do all of the osteotomies and the instrumentation. So we have a animation here, kind of what it is, if it works, which it doesn't appear to be work. Oh, there we go. So there's your nick incision. You're freeing up everything around there to avoid the dorsal medial cutaneous nerve. You introduce your burr. I introduce the burr under fluoroscopy, and I make my cut. I actually make the plantar limb first, and I do that because I think it's easier, because if you do the plantar limb second, you destabilize it. And I think that this is really important, what they showed here. I'm going to pause it for a second. I believe in TMT instability, and I think that this is classic for some of my patients, and I think this is one of the pitfalls that you can have if you're not paying attention. Your TMT joint actually gaps open if you do an aggressive translation. And we know from the literature from Roger Mann and Coughlin that with their proximal osteotomies, the more they swung over their osteotomy, the more they tightened up that TMT joint. So even in TMT instability, I think that if you're careful, you can get away with doing a minimally invasive bunion. And you drill through, you make sure you get 2 cortices on the proximal metatarsal, and then you put the screw across. Here they show you putting the second screw across. It's going to be a little bit smaller of a screw. What I would caution you, it's not like what we used to do. I don't bury the screws all the way to the metatarsal head. Crossing it and getting about 1 centimeter past the osteotomy is more than enough. The thing that I worry about is, God forbid there's some shortening, I don't want the screw to breach. And here you go, you're doing your Aiken. Aiken is sort of a green stick osteotomy. It's you leave the far cortex at the one side, and then you have a closing medial wedge osteotomy. Really, really easy and reproducible. One of the tricks I learned with this, you put the screw in, or the wire in, you measure it, and then what I like to do is I actually drill the wire through the other end of the foot, so you don't pull the wire back out when you're done drilling. And it's pretty easy. Oops. So for me, measure twice, cut once. Make sure that you are making the incision in the place that you're trying to do it. One of the goals here is you're making smaller incisions. To make a whole bunch of incisions and Swiss cheese the skin is not ideal. Make sure that you're going to make the plane of your chevron perfect. You can lengthen the bone if you need to, if it's a little bit short. You can dorsiflex, you can plantar flex if there's a little bit of elevatus there. Make sure that your guide wire for your proximal screw fixation is good before the displacement of the osteotomy. Displace your osteotomy, fixate your osteotomy, and then follow it. I would tell you, once you get comfortable, for me, I actually do the distal soft tissue release first, and I find that when I do that, I take the toe and I pull it into varus to make sure I can relocate the metatarsal sesamoid complex, and that really helps me understand some of the deformity. So again, this talks about some of the different ways that you can either lengthen or shorten the bone, and you're not making an osteotomy in line with the foot, you're making it parallel to the bone. So the bone's going to have some degree of intermetatarsal angle, and if you can match that intermetatarsal angle, you're not going to shorten it. But you can shorten it if you want to, and you can make it more oblique if you want to lengthen it, and you can also either plantar flex or dorsiflex, depending on the angle that you hold your burr at. So here you go. Very, very easy. Make sure you're getting 2 points of cortical fixation in that proximal fragment, and you see that the bone sort of grows right into it. It's not a pretty X-ray, but honestly, it looks good clinically, the patients have no pain, and it's good rigid fixation. So here you go again, these are the stepwise fashion. They actually make a little church key that goes in there. I find that easier to use. And what I do is I palm the church key, hold the metatarsal head, the metatarsal sesamoid complex between my index finger and my thumb, and I'm able to translate and control rotation and control plantar flexion and dorsiflexion. And that makes it really easy for me to get it where I want, make sure the K-wire is going where I want it to go, and then I take orthogonal imaging to make sure that it's perfect. So I don't know what that X is versus, yeah, I'm not really sure what they're trying to show here. But when you do your medial eminence shaving, this is actually the wrong burr. The burr on the right is going to be the better burr. We call it the big nasty. It's the black burr. The other two are silver. One has 1 hash mark on it. One has 2 hash marks on it. Again, for screw insertion, make sure you're putting that first 4/0 chamfered screw bicortically, and you can kind of see it getting that cortex. You need to get that cortex to get 1-2 cortices of fixation to prevent that screw from sort of floating around distally. And that second screw goes right over, and you can drive it in a little bit more. So again, you know, there are x-rays out there with people putting the screws more distally, and what I would tell you is with the amount of translation you're getting, you need to start more proximal. That way you can do an appropriate shaving. So again, this is your metatarsal sesamoid release, your modified McBride. And again, I do it all the time, but you don't have to. I've talked to people in other parts of the country, and they're not doing it. And then for your Aiken, your 12-millimeter cut burr is going to be the one with the 2 hash marks on it. You go right through, you come up, you leave the lateral cortex, and then you do your closing wedge. And you can actually see here, the K-wire is actually through the lateral skin, and that's exactly how I do it, because I want to make sure I don't pull that K-wire out. The minimally invasive, it does make it a little more challenging if you pull a screw out to get right back into the hole, because you can't see the hole. For my post-operative management, I do a bunion dressing. I let them walk right away. I tell them to elevate when they're not walking for as long as they can tolerate it, and they can start bending the first MTP joint starting 2 or 3 days out. I'm a little more aggressive than saying sedentary in a stiff-soled shoe for 6 weeks. I let them get back into a sneaker anytime after 2 weeks. I tell them that if they're going to do something, they have to do the elliptical or a stationary bike, but I let them start running at 6 weeks. And this is, again, you know, you get great mobility at 2 weeks because you're not disrupting the soft tissue envelope. It's really, you know, it's phenomenal. So the pitfalls. This is hard. When you first start out, it's hard. And it's not the osteotomy. My experience with talking to people is they're scared of the osteotomy. Don't be scared of the osteotomy. It's going to be putting that K-wire in is going to be the most challenging part, because you got to get your version right. Trust your anatomy. You know, anatomy is king. It's what I always teach. So know where your anatomy is. Know that getting the K-wire is the most important part of the case. It's not the osteotomy, because you can do a direct transverse cut and it'll still grow in. Check the plane of your osteotomies. Put the proximal screw guide wire in before displacing it. When you get more comfortable, you don't have to do that. I don't do that anymore. I actually take the foot and rotate it laterally. I hold the church key in, and I put my 2 fingers on either side of the metatarsal sesamoid complex to hold the toe where I want it, and then I drive my K-wire in. And then you put 2 screws of fixation for your chevron, do your soft tissue release, do your Aiken. So this is just a quick video showing how I do it, just so you can kind of see my setup. It's a little bit different. Hopefully it loads up here. Here we go. I'm on the hospital network, so it's a little slow. Sorry about the delay, y'all. And if it doesn't start, we'll just, there you go. So again, you can see I'm coming from the foot of the bed rather than the side of the bed. And you can see I pull it right in, pull it right out. I'm doing the osteotomy there. and I see I'm palming the church key, and I'm holding the metatarsal sesamoid complex with my fingers, and I'm putting the K-wire in where it needs to go. You see I already did her other side, so both the feet are hanging off the bed, and you can see how I could flip easily from AP to lateral without it getting in the way, and you can see I can work on both sides of the feet with the X-ray being out of my way, and that's my concern with coming from the side. And you can see what I'm doing. I'm externally rotating and putting all the hardware in, doing all the work that way. There's a quick shot of the X-ray. You can kind of see that comes up here once I do the very brief. But after this, you'll see the clinical at 6 weeks, and it's really unbelievable. Putting a little local in, no sutures, just steri strips and glue. One quick monocryl underneath the skin, and no sutures to remove, and they look great. AP's laterals just to make sure you're there, and then I do my bunion dressing. There you go. That's 6 weeks. No scars whatsoever. No bunion. No crossover. Super happy. So for me, in my experience, again, first TMT instability is real. You're going to translate that metatarsal head, and you're going to see at the base that intermetatarsal angle grows. And I think the more it grows, the more you tighten it up, so the less likely you are to have recurrence. And knock on wood, I have not had recurrence yet. The plantar limb of your chevron, trust the anatomy. You know that the first metatarsal is going to plantar flex about 10 degrees or so. So it's really going to be almost parallel to the bottom of the foot rather than downward. So you can do that cut, but for me, I like making that plantar limb a little bit longer. Again, I palm the metatarsal head with the church key when I'm positioning the wire and the screw, and then I judge if they need an Aiken after I do all of that work. Use fluoro. Fluoro is going to be a friend when you first start. It's scary enough to use a new technology, especially one that involves you trusting the way that the foot looks rather than looking at the bones, and position your patient to your comfort. Because if the patient is not in the right position, it's going to give you hell and you're going to hate the procedure. So these are some of my case examples. You can kind of see here. So this is at 2 weeks, so there's still a little bit of soft tissue swelling, but again, pretty darn big deformity here. Lateralization of the sesamoid complex. Little bit of a spur right there that I was able to take out with the aggressive burr, and you can kind of see here that's the long limb that I made right there, and you can see the IM angle is almost negative, but the hallux valgus angle is normal, and at 2 weeks he's back in shoes. He's a cardiologist out in East Texas. Again, this is another one that this is a year out, and you can kind of see that the bone does grow around it, so it makes it a little bit thicker, and did some 2-3 hammer toes there as well. Another one that, again, similarly, this is probably a mild to moderate bunion, but you can really see the difference in the shape of the metatarsal head. We know that there's a rotational deformity, and the guys down in Chile, like Pablo Wagner, talked about that light bulb appearance of that metatarsal head, and you're changing that morphology as you correct the rotational deformity in the metatarsal. And then I think this is the one that I want to show everybody, because this is the one where it's like, here, hold my beer, I promise you it works. So not a big deformity, but sesamoids are shifted. It's got that light bulb appearance, but look at the intermetatarsal angle there. I mean, that's clear TMT instability. I don't know what happened to my screen. Hold on, let me go back down to it. So that's clear TMT instability. But here she is at a year. She loves it. She's running 6 miles a day. She's a PT out in West Texas. And I've gotten a whole bunch of people from her. They can't believe that she's so good. But look at that bone growth. I remember showing one of my buddies from residency who's a foot and ankle surgeon up in Pennsylvania. And he was like, BS, there's no way that's going to heal. There's just no way. It can't. And I showed him the 1-year X-ray, and he's like, I can't believe it. I can't believe that that's real. So it works. This is with one screw. There was no rotational instability there, 120% displacement, and you wind up really getting a nice result. The patients are very happy. And if you look at the skin shadow here, you see how big her bunion is. and you kind of see it here at a year, and she's just really darn happy. So I'm going to hand it back off to you, Dr. Davis, and we can go through everything, and if you all have any questions, I'm happy to answer.
So Justin, I have a couple of questions. You said you do a distal soft tissue
You're
release.
on mute, Dr. Davis.
No. Yeah, can you hear me now? Can you hear me? No.
I can hear you, Dr. Davis.
Okay. Yeah, Justin, can you hear me? Yeah. Yeah, Shannon, you can hear me?
Yes, sir.
Yeah. Justin, can you hear me? No. Okay. It's going to be a tough one. Yeah.
We might want to text Dr. Kane that he may have muted the screen.
He did something when he yeah. He's on mute now, but
We'll get a hold of Dr. Kane, take care of it.
okay. It's hard for me to do cases when when I don't have anybody to do them with. So a couple of things that Justin has evolved to that we can talk to specifically. First is he does a distal soft tissue release in most of his. I've gotten to the point where I only do it when I can't reduce them to neutral or past neutral, at least into a little bit of varus.
I still can't hear you. I'm sorry.
Yeah, Justin, something's up with you. You might have to sign out and then sign back in. Yeah, I don't know why.
Hey.
You got it? Any better? Can you hear me? You got it? And typically that release is just done with a beaver blade, and it's pretty simple to do, but it is something something that you do. So a couple of questions. First is, have you encountered any stress fractures after placing 2 screws? How aggressive do you get with burring the distal medial med shaft or the med head eminence? So I have not seen any stress fractures. I have the one complication I've seen in my patients were some settling, and the patient was 80. And so in theory, I think that probably is something that you can see, because we all know that the fixation in those folks are always a little iffy. But I have not seen any fractures through the hardware. And now if you look at the literature, that is something that has been reported, but I haven't seen it. I decide whether to burr the distal medial med shaft or the med head by feeling the foot once I've done with the procedure. So I've done my shift, I've put the screws in, I've done my Aiken, and if there's a prominence at that it's usually the medial med shaft, then I will slide a burr, and I'll use one of the wedge burrs, a 3.1 wedge burr, and I will slide it up from the bottom, from one of the holes that we used for the screw, and it's fairly easy just to burr that off. I have one time felt that the med head was still prominent, and in that patient, I used the same incision that I used for my osteotomy and put that up over that. What I have not done yet is a chylectomy and the bunionectomy together. My feeling is that on those patients, you really have to decide where the pain's coming from, because I do MIS chylectomies.
I did that today, actually. I slid it over, felt a pretty prominent dorsal osteophyte on the metatarsal head. And what I did was from my lateral distal soft tissue release, I slid one of the aggressive burrs underneath there after dissecting it out, and just did a chylectomy right through that incision.
Yeah, I mean, you certainly can move them, but I always hate to feel like you're fighting it. So one of the questions was, how aggressive are you burring that distal medial met shaft? I saw on the one that you shifted 100%, you certainly did that. But I was telling them that what I do is I feel, and if there's a prominence, then I'll resect it. And that happens, maybe 25% of the time. What's your experience, Justin?
I think the more you translate, the more likely it is that you're going to feel that medial edge. And I don't use the x-ray as my litmus as to what I'm going to do. I burr until I can make sure that I don't feel any bony prominence over that medial metatarsal. And the way that I approach it is, because I've done that periosteal elevation where I do that my chevron, I come through that incision and I come under the periosteum and I go ahead and I shave it down until I can't feel it. And then I take it out and I use an angiocath and I just irrigate it with normal saline until all that junk comes out.
All right, the next is there an advantage of leaving the plantar shelf as opposed to the transverse cut, to a transverse cut?
I mean, I don't think the literature supports that, but I would tell you, just from my comfort level, I want to have as much bony opposition as possible, because even though I showed that x-ray with 100+% displacement, again, it goes back to our classic teaching that we know that we need bony opposition to get healing. So if I can leave that plantar shelf there, I know that there's at least a little bit of bone hanging on where they're in communication. And maybe some of those, osteoblasts get across there, and that's where you get that healing. But that's just my personal preference.
I've found that the reason I do it is because when I'm holding the head and the shift, I can push up on it and the shelf catches. It catches and holds it there. So that's part of my maneuver, is I shift it over and then I hold it and I push up on it, and it keeps it from dorsiflexing, but it also allows me to prevent it from plantar flexion, which is really what it wants to do. And so if I can put my finger on that as I'm making my shift, I think it just reduces that, and that dorsiflexion, plantar flexion, it gives me something to push against.
Yeah, I think that certainly helps. That transverse cut, I just worry that you're going to have a hard time controlling plantar flexion, dorsiflexion, rotation, and where it's going to be. If you have some plantar shelf of bone, you really have a lot more to work with, and you really have a lot more to hold on to.
All right. Another question is, when do you decide to use 2 screws versus 1, and how do you feel about surgeons only using Steinman pins?
Well, for me, I make that decision based off of intraoperative live fluoro. I'll put my 1 screw in, and I'll take the toe and I will crank it into as much varus as possible. And if there's any toggle whatsoever on live fluoro, I put a 2nd screw. It's maybe about 10% of the time. I really haven't seen a lot of people who've needed a 2nd screw when you get that bicortical fixation with the screw. I mean, you can use Steinman pins. I don't think there's a reason not to. I think probably my biggest concern with using a Steinman pin is the fact that it's a fully threaded screw. You're going to control where you put it out to length. If you use a smooth pin, that thing can toggle, that thing can get longer, shorter. Plus, how are you cutting the pin down, or are you taking the pin out? And I think that defeats the purpose, for me at least in my practice, of getting these guys up moving super quick and really having a much quicker recovery.
You'd have to use a threaded pin for sure.
Yeah.
Okay. This is from Dr. Alan Weiss, who has said, Dr. Kane, point of information regarding timeline for mental insertion In the early 70s, several podiatrists were doing this for bunions, et cetera, and got totally shamed and ridiculed into stopping this technique as not utilizing reasonable surgical techniques and principles. Just a point of information, Dr. Weiss says, my bell bottoms are again back in fashion. So Alan, you're absolutely right that happened. It was not, I mean, it went all the way into the 80s. There are some significant differences in what Justin just described to you and what was happening in the 80s and early 90s. The burrs are different. The fixation is dramatically improved, and the whole concept of fixation with early motion is changed. And so I do think that the seeds were planted back in the 70s and early 80s, and there was a textbook on minimally incision surgery and all that. But I do think that the technology has caught up with the idea. Yeah, comments on that, Justin?
No, I agree.
Justin's too young to really remember that time, but
I wasn't born in the 70s.
Thank you very much, and you can quit talking about that right now, if that's all right. All right, so we're going to do some cases, and so the first is a 55-year-old, super active female, long-standing bunion, and has an unstable second MP joint. And she would tell me that she loves to speed snow ski, and the second toe came out while she was snow skiing, and she fell and she didn't like it. So so she's complaining of both the second toe and the bunion, here and here. How do you approach this, right? So this is a common problem, is the bunion, which hurts her, is causing her to have second MP instability also. How do you address this, and what's your approach in today's time?
Yeah, so I tell all my patients that if you're just putting it into layperson's terms, I call the big toe the bully of the foot. I mean, the big toe is going to be your driving force for deformity of your lesser toes often, and without correcting the underlying pathology at the hallux, you're not going to be able to keep your correction. You're going to have to do a plantar plate repair here. I mean, it's clear that the toe is subluxated and the plantar plate is insufficient. So I think my concern here looking at this, if you look at the plantar aspect of metatarsal head, is it does look like that maybe there's some metatarsal sesamoid arthritis. But again, for me, it's a lot more clinical than it is radiographic to see if they hurt there. A lot of the times, at least in my experience, once you get those sesamoids re-reduced into the cristae, so they're not pushing on that bump of bone in between, they become a lot more quiescent. They don't cause as much pain. So if the
she has no sesamoid pain. Now, if you're going to do something to the plantar plate, are you doing, I think the guys in Europe would say, do the distal metatarsal osteotomy with a little soft tissue release on the medial side of the second. But you got to, if you're going to do 2, you got to do 3, 4 also. Have you done that? I did not see any pictures of the DMMOs.
I don't do 3 and 4. I do what hurts. So for this, I would probably do a really, really, really minimal while osteotomy, push it out of the way, find the plantar plate, re-imbricate the plantar plate into the lateral and the medial collaterals to get it to sit where I want to sit. And as I approach the bunion, rather than doing a dorsal minimally invasive, because you're going to be there anyway at the second, what I'll do is I'll do some blunt dissection down to the lateral aspect of the metatarsal sesamoid complex and do a formal modified McBride through the incision that I make where I'm going to approach the second. So I would do this as long as there was no sesamoid pain. I would feel comfortable doing this with a minimally invasive and then treating the second. I would probably put a screw down the second as well because I worry about the second forming a hammer toe.
So this is what I did actually. Did a PROstep bunion with an open plantar plate repair in a while, and she was back skiing this season until they closed the mountains. So So it was an interesting, because it was the first one that I did that really came in primarily for second toe issues. All right, 60-year-old, hallux valgus, bunion pain, and she's got these windswept toes. And to me, these are some of the harder patients that we treat because it looks like their IM angle is minimal, but the metatarsus adductus kind of gets that out of the way. Her sesamoids, she's clearly got a rotational issue both in the sesamoids as well as in the metatarsal. So Justin, how do you address this? I mean, this is a little different.
Yeah, I'm concerned because the MTP joint there actually looks congruent, and if you got it back over, I'm worried that you're going to have issues with pain. So I would probably be more prone to fusing this and then addressing the lesser toe deformity after that. Again, her second looks pretty long here too, so possibly even putting a while on the second, just because if you do shorten a little bit with your MTP fusion, I worry about some transfer metatarsalgia.
Well, Justin, so when you when COVID leaves Texas, I'll come down there and be your partner. So yeah, so I agree totally. I think these metatarsus adductus, the fusions, in my hands work so much better. I think in really, really young patients, I'll do a lapidus with multiple met osteotomies, but this is one that in a 60-something, I think it was fairly simple to convince them to do a fusion. All right, so 4 years before, she had a lapidus, and she also, you can see, has an arthresis screw, which I did, and a gastroc slide, because she really had pain with flat feet, but also this unstable bunion. So I did the lapidus. So she comes in now with these x-rays. She's complaining of some flat foot, but definitely complaining of bunion with malrotation. So how do you handle this? I mean, she's got an unstable medial column. How do you handle this with MIS?
So I think this is an easy, well, I wouldn't say easy case. I think this is a good indication as long as she's not having real flat foot pain. She doesn't have a lot of uncoverage at the talonavicular joint. Simmons' angle isn't all that off. Miri's angle isn't all that off. I think this is one where I would pretty much tell the patient, hold my beer, watch how much quicker you recover from an MIS rather than from doing a first TMT arthrodesis.
Okay, so I thought she had a pronated hallux, and she really did. And I tried to schedule her for an arthrodesis, and insurance wouldn't pay for it. So I did an MIS MDCO with a lapifuse, and you can see how I got her rotated back, and I think I still would have done this, and you can see how Mary's angle got fixed with these two procedures. So yeah, this is one I think the lapidus really works good. Another question is on our Q&A is, how do you approach hallux valgus with first ray elevatus? Do you change your direction of your burr or anything? Any tricks to that?
So there's two ways to go about it. You can change the direction of your burr to bring it plantar flexed as you slide down, so your chevron can start more dorsal medial and come more plantar lateral. So as you're sliding down. The other way, if you're not happy completely, you can finish dialing it in just by plantar flexing it a little bit.
Okay, I have seen that for sure, and I usually will handle it by just raising my hand a little bit when I make the initial insert. Painful hallux valgus, kind of got that rounded head that we see a lot. This is a slam dunk for you, MIS?
I would definitely do this MIS. I think what you'll see is as you correct this, that IM angle is going to open up, and it'll surprise you how much it opens up, and it's going to allow you to get a lot more translation than you think you're going to get, and you're going to get rid of that light bulb appearing metatarsal head. And you're going to have to do a soft tissue release on this, and probably an Aiken as well.
All right, let me, sorry, I have my Q&A open. So I did a big shift chevron. Oh, actually, I didn't do this one. Someone else did it, but a big shift chevron Aiken, and I ended up getting the X-rays, and she looked at this at first post-op visit. At 6 weeks, she's recurred with this distal, and it looks like there's a rotational something going on here, because the sesamoids now look worse after 8 weeks, and she's not happy, you can imagine. So how do you come back from this? Would you now do an MIS in someone that's already had an open procedure?
So I worry about the amount of medial resection there, that if you try to get a big correction distally, you're going to wind up having hallux varus as your next complication. This is one that I would probably do a TMT arthrodesis and then assess if we need to revise the Aiken, and I would go from there.
So this is one that I did a Lapidus procedure, and agree with you. I was able to, you see, I get the sesamoids right by derotating it, and got her down, and she did gangbusters, but 2 operations. Here's a 55-year-old with a failed Lapidus. Now you've got a fixed IM angle because the TMT joint fused, and has had a bunionectomy. Can you do this MIS?
I think you can. One thing that you have to look at is that the toe is definitely an elevatus, the metatarsal, so it's dorsiflexed through the Lapidus. But I think if you take that one cross screw out, you can get screws through that. And this is one that, if you're comfortable and you've done a lot of these, this is one where you can get that metatarsal head plantar flexed, and you could really, really get it over nicely, and you don't have to worry about the IM angle shifting anymore. You'd probably get, this is one where you'd get over 100% displacement.
Okay, so this is one that I really felt had a positive grind, and so I went ahead and did a revision Lapidus and cut through it, and then came and did a fusion, and I do my fusions open. I don't do those MIS. Have you done some MIS fusions?
I haven't. One of the things I worry about is just the geometry of the metatarsal head and the base of the proximal phalanx. I want to make sure that I get that good cup and cone shape, so I can really make sure I suck it down. And again, I like putting a plate on it because I weight bear them from day 0.
Yeah, and I don't love doing this operation where I fuse both of those joints. I mean, they're
Really
stiff,
good.
and they really are limited on shoe wear. So 53-year-old, lifetime of bunions with increased bunion pain, and she's also got second met pain. Again, straightforward for you?
I worry about the second met pain. I think you have to have at least in the back of your head that maybe there's some plantar plate insufficiency. I'd probably go in there and do a Lachman's test in the exam room, make sure that there isn't any plantar plate insufficiency. It looks nice and dead on there. But this is one where you can get a little bit of length if you wanted to with an MIS approach to offload that second if there isn't some plantar plate insufficiency. But I would have a low threshold to go and do something to the second if I was concerned from clinical exam.
So in this one, I did a big shift chevron in a while because of the second. I now in my practice, I'm tending on the ones that have significant, what I would call your medial column instability. I've tended to go to Lapiduses for these. And this is really just a scarfy chevron. So it's similar to what you described, and you showed that picture of the scarf. And you're able to shift it. I mean, you can't really shift it distal, so you're going to have to do something to the second, which is what I did here. All right, 41-year-old. Now this is you have to keep up with this one. Severe diabetes, neuropathy, had a calcaneal fusion 4 years before, and she's complaining of her bunions. Right, so she's neuropathic. She's got every complication that a 40-year-old could ever have with diabetes, except she still has both of her feet. I've operated on both sides for Charcot. You mentioned that diabetes was a contraindication for MIS. And I talked her out of this for years, 2 years. And it's not like she wears special shoes, you know, because I would have thought a fusion would be reasonable, but she didn't want to hear anything of it. MIS on these?
Is she having pain at the interphalangeal joint or the MTP joint? Because she's got that really classic diabetic forefoot.
Yeah. So I'm going to have to do something to that also. Yeah.
No, I still like Clayton Hoffman for these. I worry about ulceration. It looks like she bridged from that flipper foot across the CC joint. So I'm worried about how rigid they are. Again, you know, we see so much diabetes here, and I see so much foot ulcers here. I have a really low threshold to take out points of pressure and do med head resections, not for the first, but for the lessers, and then maybe do an IP fusion.
Well, I didn't want to put much of a scar on her. So honestly, this was my patient alpha, my first patient. And I was able to fix the hallux IP by doing a little Moberg. You can see I dorsiflexed it.
Mm-hmm.
And she loves it and wants me to do her other side, which she's not. She got beams and bolts on the other side. I go, no, I don't think I can do that. But anyway, there's one other that I'd like to show. Yeah. So this is a lady that I did a Lapidus on. And 10 months post-op, she comes in complaining of a recurrence. And we've talked about it a little bit, but I really think, you know, normally I would do an open distal chevron for this recurrence. And this one I did an MIS with a single screw and an Aiken, and she's done great. So I do think you can use it for revisions, which is really nice to know. And I didn't get a huge shift, but I got enough where I think I almost just kind of rotated it as I shifted her. And so that's where we are. All right. So I think we are over our time allotment. Shannon, do you want to come back on? Justin, always fun doing these things with you. And
Absolutely.
And I can't tell you, I know you had a busy day, and I always appreciate working with you and hearing your views on things.